For those of you who don't know about Reform, we are a public services think tank that focuses on delivering value for money within the public sector, and we really focus on trying to make public services better for people and delivering better outcomes for them. So the way that we do that is that we hold various events throughout the year, and also publish research in different areas of the public sector. So we cover quite a lot, actually, looking at education, healthcare, criminal justice, and welfare and pensions. And for the past 2 years in our work, we've been increasingly looking at how to deliver digital public services, and digital healthcare being a core part of this. We've looked at various projects, such as how to deliver AI in the NHS, but we've also looked at potentially slightly more contentious topics, like our most recent report, and you do have some copies available at the back of the room, which is looking at public-private partnerships in the health tech space and what a fair apportioning of value could look like between citizens, the private sector, and the NHS when there's access to data to create a product. So a little bit more of a contentious topic there. So we have an absolutely jam-packed agenda for you today. We will be kicking off pretty soon with a patient who is here with us today to really remind us of, you know, why is it that we're all here, and why is it that we all care about digital health? Well, it's really ultimately for the patient and to try and make services better for the patient. So we thought putting the patient at the very center of this conference would be absolutely essential. We will then be kicking off various sessions. So the first one really trying to see if digital healthcare has just been a decade of promises. So I know that, you know, all of us here are definitely digital health enthusiasts, or at least people interested in the area. But I think sometimes having a little bit of an introspection exercise and really asking that difficult question of, has it really delivered all that it has promised to deliver? So we thought it would be quite a sort of interesting way to start today's conference. The second session, we will be having a little break, a half-an-hour break between the session 1 and session 2. The second session will be looking at how to get the implementation rights of digital health technology, so all the way through making sure that we get the right data infrastructure and the kind of data side of the equation right, but also how do we deliver high-value partnerships between the private and public sector when they're sort of working together to implement digital health. We will then be moving on to a user voice session, as we called it, where here we will have a patient who is also a doctor herself talking about her experience in helping digital health companies design some of their services and products, and the importance of having a patient voice when you actually try to deliver these technologies. And finally, the final session of today will be looking at the future of healthcare, so a bit more of a forward-thinking piece to leave you at the end of the conference with that. And just one final word is thank you so much to our sponsors, without whom today would not have been possible. So thank you so much to Baxter, PA Consulting, Dr. Link, and Taurus, because without your support, these type of events would not be able to happen. So if I could call Charlene on stage. Great. I think we will both be sitting here. Can everyone see us well like this? Yeah? Great, amazing. So Charlene here, sat right next to me, is a bone cancer survivor. She is also a cancer support coach and a community entrepreneur wearing absolutely multiple hats. She is also an ambassador for Black Women Rising UK. What is it that you don't do? Sorry, actually, ooh, there we go. We'll have a mic for you. I think it should be on. Yep. Great. Yeah, amazing. So actually, Charlene, to start us off, could you tell us a little bit about your story and how was life before cancer? How did you find out? And how was the care that you received?
Okay, 8 years ago, I was diagnosed with a rare cancer, which was osteosarcoma. It was a bone cancer. I found out in 2011. At the time, I was studying, doing a business administration degree, which I had to cut short, obviously. Yeah. When I found out, it was during the summer, I was a play consultant with children delivering activities. I noticed I was unable to run, walk. I was in a lot of pain in my left knee.
Okay.
I went straight to my GP. They gave me painkillers. I immediately went back because I knew something was wrong and the pain just kept continuing. I immediately got referred to the hospital.
Okay.
My process personally was very quick and it was amazing.
Yeah.
I done several tests. I was offered a biopsy by the Royal National Orthopaedic Hospital, and I think during that week I literally found out I had cancer. It was very quick, and I got invited in back to the hospital, went with my mum.
Yeah.
And there was about 3 consultants there. They explained why I was here, and to be honest, at the time, I didn't think it was that. I thought it was a fracture.
Okay.
So
Quite a different outcome.
it was, definitely. I was totally distraught, shocked. I think everything past the word cancer I didn't take in at the time.
Yeah.
So they gave me the option. Well, there was no option. In order for them to save my leg, they had to remove the tumour, give me a full knee replacement. At the time, they wasn't sure if I was to have chemotherapy or radiotherapy.
Yeah.
So the operation was done within weeks.
Okay.
So
And
That's
how did you feel with? I remember you telling me when we were having conversations preparing this event that you actually, even though you didn't have radiotherapy or chemotherapy, the actual effect of the treatment on you was quite strong, and that you were sort of completely out, and it was.
And this is the thing, people
Yeah.
think because you haven't had chemo or radiotherapy, you're lucky. And in fact, no, it was the same type of effects. I was on a heavily full of medication. I was homebound, unable to walk.
Yeah.
You know, I felt so isolated.
And how do you think you could have found out potentially about some support groups that could have potentially helped you, or patient groups that could have helped you understand how other patients with similar conditions have gone through that experience?
I think, digitally speaking,
Okay.
for me personally, it would have helped if I had more of a digital platform. Obviously, I wasn't able to go out physically to support groups. Don't get me wrong, there was support on the telephone.
Yeah.
I love digital technology anyway.
Great to have
and
you
I know
here.
it's exactly, so I know it's changed over the years since my diagnosis, but I would have loved to just kind of seen, the process of what was going to happen to me.
Right, so you mean the operation itself,
The operation
being able
itself,
to sort of visualize what was going to happen?
Exactly. Do you know what I mean? So,
right. And in terms of, I guess, you were sort of saying, given that you sort of couldn't move, you think maybe sort of chats online would have been able to help, or what type of support do you think would have been most adequate, maybe video conferencing? Or?
Yeah, of course. I think things like Skype, that could have been used in my care.
Yeah.
Not just peer support, I think maybe medically as well. One time my GP did actually come to my home, which was so nice. Do you know what I mean? So, yeah.
Yeah. And in terms of, I guess, the sort of people that you met through, I guess, sort of being a cancer support sort of advocate, what do you find would be the most useful thing to potentially sort of easy, quick win that we could do for most patients in that situation in terms of delivering potentially more support? Is it better signposting to, say, community-led support groups or patient support groups, or?
Yes, I think so. Things that NHS is doing an amazing job, but just an example of, in the black and ethnic community, wigs are not available. If you've got cancer, they're either sold out or you've got to go and buy your own wig. These are the things that need addressing.
So that's really interesting, actually. On that point of diversity, do you think that ultimately the advice out there is catered too much to the same type of person and doesn't take into account?
I think so, and I think we need more people speaking up and, just finding ways of catering to everyone, their individual needs also. So that's why I'm here.
Yeah, exactly. Well, great. So thank you so much for the interview. And I think I will sort of call on the panel one for the session one on delivering, oh gosh, I'm getting all muddled up. Digital healthcare, decades of promise or not. But thank you, Charlene, and if everyone could sort of welcome me in, thanking you so much for your testimony today. No, thank you. Yes, please. I'll keep the mic. Great. So if I could call up Denise Silber, who is here with us today. She came all the way from Paris, traveled last night, so thank you so much for being with us. And she will be talking about the bad ideas or poor implementations in digital health. So your clicker is here. There you go. And the mic is there. Fantastic.
So thank you very much, Reform, for inviting me for this exciting topic. I'm actually a digital health events and communication person, and I believe that there's a lot to be gained by bringing people together to discuss these important issues. When you see the image above of the physicians, you might wonder why I put that there. It's because I believe that physicians have traditionally been given a hard time. They're often pointed to as the source of resistance to the advancement of digital health. And that's the question we're here to debate today, is how can we accelerate unlocking the promise for digital health? I believe that it's been unfair, and I'm going to show us why. First of all, we spoke about digital health for the past 10 years. I would like to propose that it's been half a century. A man from the 60s with the predestined name of Larry Weed is actually considered a pioneer of the electronic health record. And at the time, the record was presented as the most useful, amazing tool. And here we are. So this was in the late 60s. If you go to PubMed, National Library of Medicine documentation, you will find articles going back to the 60s and 70s saying, this is what we need. And yet today, if you look at the world with some exceptions, such as maybe Estonia or Israel, Denmark, there is no place that can say that all of the information of the patients is in one place and available nationally to any healthcare professional that would need it. There is no pure interoperability as one would think, and yet this is the oldest digital health tool. Let's take a look at telemedicine. Okay, so there are many articles that have come out, such as this, Death by 1,000 Clicks, which reminds me to say that not only is there not this interoperability, but there is definitely demonstration of the fact that electronic health records and the clickitis, the need to be clicking through the consultation with the patient, is contributing to physician burnout. It's certainly not the only reason. Telemedicine, now some would say that telemedicine goes back to the ancient Greeks because they would send a runner to another town to find a solution if locally they didn't have one. But let us just say that telemedicine, modern telemedicine might have begun with the time of the space station with NASA, let's say, again, around 40 years ago. And no one is telling patients that mathematically it is impossible for them to be located near the team of healthcare professionals that would be the most relevant, that would have the most experience in dealing with their particular condition. It's just not mathematically possible. You should be able to connect with anyone, anywhere in the world who might know of your case. Think of the rare disease centers all over Europe where people cross borders in order to find a doctor who can properly diagnose. So telemedicine, people should have been in the street demanding that there be telemedicine, but we don't tell the patients that there's an issue with quality differences on medical conditions and not finding the right diagnosis or treatment. And so we don't have this perfect world of telemedicine. In fact, it's always been used in extreme situations. Yes, Norway, because there are great distances, or prisons, because we don't want to send too many physicians into the prisons. So it's always been used by where can we not avoid using it, and it's been considered not too human. And as with the electronic medical records, there are thousands of different approaches to telemedicine, different kinds of tools, and so nothing has really scaled. Now we see with startups that there are a lot of consultations that are made possible for people who want to pay to use these websites, but telemedicine has not succeeded in delivering its promise in terms of scaling up. Another example would be websites. So we were very pleased when Clinton and Gore made the National Library of Medicine available, and they created this amazing website. But then there were thousands, and then hundreds of thousands, and millions of healthcare pages on the web. And what happened there? People started complaining about the quality, saying that any dog or any Tom, Dick, and Harry can produce information, and it's not going to be of good quality. So then other people came out with yet another digital health tool, which is, and I was invited to many of these. I've been in digital health since the late 90s. I was invited to participate in government and private and not-for-profit groups on developing codes of quality so that medical information would be good. And what happened there? Yet again, we went into the same error of having too many examples. So above you have the American ones, on the left you have European ones, and then there's also the use of general ethical type evaluation systems and applying them to health. So this is just a few examples. There were probably at least 100 ways proposed to improve healthcare quality. In France, there was an agreement with HON. None of it worked because, again, the proper communication around it and decisions on how to scale up were never taken because it's very difficult. Yet another example is that thanks to mobile apps, and by the way, there are over 300,000 mobile apps that were counted, I believe, in English by an organization last year. Mobile apps made it possible to drive connected objects with their sensors, and so now you have from head to toe and in every category, every startup, every research organization coming up with the better form of sensor. And you can imagine, from electronic health records to telemedicine to this, if you were a physician, you would say, well, what am I going to do with all these things? Or if you're, even if you're an IT specialist, which one do we take? Which one deserves to be scaled up? And we've had this ever since industry began. We had this with cars. When cars were invented, there were tons of cars, but it wasn't to the number of thousands that we have now. And I believe that that's because of the reduction of friction thanks to the internet, that anybody, you have examples of teenagers, high school students in science fairs are coming up with ideas, startups, big companies, little companies. Hospitals now have all their accelerators. It's like, enough. There is so much innovation out there. Why don't we choose what we really need and how to scale it up? There should be scale-up specialists. And so the question is, have we learned that healthcare, every time there's a new platform that comes out, it doesn't come out for healthcare, then healthcare gets a hold of it. Like the electronic health records started because there were computers. Then there was the web. Now there are connected objects in general. Healthcare then gets a hold of it. Then all these people start saying, but we need all these things. And it's true, there are many problems. We need to break the cycle. And I believe that it is by bringing people together and bringing the healthcare professionals into the equation from the very beginning, bringing the patients. That goes without saying, and I appreciate that there is a patient speaking here because that didn't used to be the case. So we need to bring people together and we need to give them the goal of what can you choose that will scale up and perhaps put more money into that than into pure new innovation for a certain time period so that everyone can benefit from it. Thank you.
Great. And now for the next talk of the typical trap of the tech-first approach will be Emma Bradley, who is Product Strategy Lead at NHSX. There you go. So here's the mic. Thank you.
Great. Thank you for the introduction. So I was thinking a little bit last week about what I was going to talk about today with this title, The Typical Trap, the Tech-First Approach. And it made me reflect a little bit about why I work in technology. I may not look like your usual stereotype, and I'm probably less of a match on paper. I don't have a STEM degree, I can't code in SQL or Java or any other coding language for that matter. And I'm not that bothered about having the latest iPhone, certainly not enough to go and queue up for it at an unearthly time in the morning. But I suppose the thing that I am bothered about is the everyday moments that we have. It's the everyday interactions in our day-to-day lives. And those are the moments that matter. These moments are often magnified in a health and care setting, and particularly for patients and staff. My colleague Pip came into work a few weeks ago, and it had been International Nurses' Day on the Sunday beforehand. And she was saying that on that day, some of the volunteers at her hospital had come round at about 4 o'clock with cups of tea and flapjacks for all of the nurses to celebrate. And she said that made her day at that time. And obviously in the NHS, we are not in the business of surprising and delighting customers and patients in the way that the private sector is, through customer experience initiatives and campaigns. However, technology is a key enabler to improving health outcomes, people's experiences of health and care, managing population health, and creating a sustainable NHS for the future. To do this, we need to empower people to manage and participate in their health and care, meeting their user needs, targeting prevention, and improving health outcomes. Sorry, just take a moment. So in order to do this, we've just heard from one of our patients, and today we have lots of talks on user experience and the approaches we can take to service design. But one of the things that I wanted to talk about today is how we've taken those approaches to improve our own products and services. So recently, we have looked at the transformation of NHS.uk, and user research has really been pivotal in that transformation. One of the first things that we looked at was medicines. So before, there was one page for paracetamol. We've done lots of user research on this, and including research with adults and children, parents, and as a result of that research, we now have 2 pages for paracetamol, one for adults and one for children. This means that the information is clearer and people are assured that they are giving the right dosages. One of the next things that we looked at was type 1 diabetes. So we did some discovery workshops on type 1 diabetes with patients, and we decided to focus on a particular part of the journey, and that was being newly diagnosed. This is a time that is often stressful and overwhelming for our patients, and there's lots of information about the condition when you are newly diagnosed. We have transformed the content pages on type 1 diabetes so that they focus just on the information that you need to know in the first few weeks of being diagnosed, and looking at the condition not necessarily from the way that our clinicians look at it, but more from how patients experience it. And then finally, we have completed user research with disabled people to improve the accessibility of the website. So we found that people with screen readers, when accessing information on do and don't lists, need the do not command at the start of every line. Otherwise, the command could be interpreted as a positive one, which is obviously dangerous. So we now have do not at the start of all the lists for that reason. But of course, it's not just the devices that we hold in our hands or the click-throughs to pages. When we think about meeting user needs, we need to think about meeting the needs of all users involved in that patient journey, patients and staff alike, as well as the underlying infrastructure that supports it. One of the examples that I particularly like is the experience of Julie Hay, who is a community midwife in the hills of North Cumbria. Julie has been helping pregnant women and using Wi-Fi to record information in real time. She tells the story of a patient that she treated. It was a lady that was unwell in the morning when she went to visit her. She ordered throat swabs and recorded all of the information using Wi-Fi at the time. Unfortunately, the lady became unwell and collapsed in the afternoon and was taken to hospital. The clinicians at the hospital, they were able to see the information that Julie had provided in the morning and act quickly, and it turned out the lady had sepsis, so it was good to have the information straight away. So, sorry, just wrong slide. So that has really improved that journey. And when we think about this in the NHS, I can see why we sometimes take a tech-first approach. Having worked in an acute trust myself, technology often presents itself as a burning platform. But going forward, we need to look at both of these things in order to realise the vision set out in the Secretary of State's technology vision, as well as in our NHS long-term plan. And I think the way that we've previously approached this in the past can be set out on two axes. So the vertical axes, I like to think of it as digital maturity or technology transformation, and the horizontal, service improvement, clinical pathway redesign. And those things quite often have happened in silos in the past or not fully joined up. And going forward, we need to ensure that there is a diagonal trajectory in those things to make sure that we can achieve whole system transformation. And one of the things that we are doing to enable this is facilitating a digital ecosystem for patient-facing products and services. So you can see here the core components. We have assurance. So this is our code of conduct and our standards, whether they be security standards, clinical standards, making sure that the right clinical governance is there so that the products are assured from a clinical perspective too. Then we've got our platforms and services. So we've got our national platforms and products, the NHS app, nhs.uk, our apps library, as well as the various APIs and SDKs to support those. And then we've got the rest of the digital tools and services within the market. So some of you might be wearing Fitbits today. There's national services like the National Blood Donation website and app. There's location-specific services, so things like online consultations, which may be provided by different providers depending on where they're commissioned. Organisation-specific services like PHRs, and condition-specific things like to manage long-term conditions, such as diabetes apps. And these things are enabled by things like NHS login, so a consistent way to verify a person's identity, and our directory of services to find the right service for you. These are supported by an interoperable data layer, and data must be interoperable now and going into the future. And to do that, we need the right standards in place to make that happen. And only when we have this ecosystem fully functioning can we have those integrated journeys which lead us to that diagonal trajectory, making sure that we meet user needs by enabling them with technology. Thank you.
Thank you, Emma. Is this one? Okay, maybe I'll just do this one. Sorry. There we go, great. So if I could call Pete Traynor onto the stage, who's the Strategic Design Director at Us AI. There we go.
I didn't even know that you had that slide in your pack.
There's the
Death
mic.
by 1,000 clicks. So my name's Pete. I own an AI business in London. We're looking predominantly at how data and machine learning enriches the world and life for human beings. We're very aware of the fact that there's a huge amount of screens swirling around in the world, and for the last 20 odd years we've been codifying everything to the detriment of humanity. So quite a lot of our mission is to try and remove screens from people's lives, and that's how we approach things. We're doing quite a lot of work in some quite dark spaces, so suicide prevention, suicide prediction, very, very controversial, very ethically dubious, keeps me awake at night in many, many ways. So we're aware of the downsides of bad design, especially design led by data. So we come at everything with a lens of trying to do the right thing for the right people at the right time, but we're kept awake. We are kept awake. So I'm kind of here, I guess, to represent the downside of the good stuff, which is my life. Obviously, there's two types of people that we're talking about here. In the book that I wrote a few years ago, I have a real problem with the word user. Sorry, Emma. I have a genuine problem with the word user. We assume that people are numbers and clicks. We're not users, we're human beings. And on one side of this equation, we have people that need care, and on the other side of this equation, we have people that are trying to deliver care. And I think we need to just assume right from the very beginning that these are fallible, these are not technically savvy people in a lot of cases. And that's, again, the reason we're looking at data and AI in this particular space is because we want to try and make sure that those people get the right kind of care and the right kind of attention at the right time without clicking through 1,000 screens and so on and so forth. And when we presume that people on one side of this equation are tech savvy, we're creating too many screens and too many clicks and too many things that they have to do and too many decisions that they have to make, even with the greatest of intentions. And on the other side, we have clinicians and nurses and doctors who don't have a huge amount of time in the day and are trying to do the right thing and get to people at the right time and so on and so forth. But it's all right, because we're all digital now, aren't we? And I love this picture. I use this a lot. This is St. Peter's Square. At the top, you've got the Pope's inauguration in 2005, and then you've got 2013. And that's the world we live in right now. That's the world that we live in, where everybody is digital, everyone is a digital citizen, everyone has a small computer in their pocket, everyone accesses all the services they need on their phones, and everything's wonderful. And look how far we've come in the last 15 or 20 years. It's been remarkable. And I've been in digital for 25 years and contributed to quite a lot of this very strange behavior, which I apologize to my kids about a lot. There's a few rebels in the bottom that don't have screens. But I think we need to just dwell very quickly on the people that we've left behind. And when we make an assumption that everybody's digital, that's where the disaster is looming, I think. And that's where we need to think about design of digital services in a slightly different way. So we still have, last year, kind of 8.4% of adults that still never use the internet, 20% of disabled people that have never used the internet. And that's from screens, phones, all the different touch points. And I'm imagining, from the research that we've been doing, that most of the people in those sort of numbers are the people that probably need healthcare the most, in a lot of cases. They're the most vulnerable people. They're the people that, struggle to do these things. So when we go into the world going, everybody's digital and everything's wonderful and everything's amazing, and we're spewing out data and we can process it, and isn't AI wonderful, which it will be, it's not right now, I think we leave a lot of people behind. And so that's something that troubles me greatly. Just a few more numbers. I love a stat, and I'll put my slides up somewhere. So that, people without internet, 81%. Retired people, you get it, you work in this space. They're not, they own a smartphone, but they're not engaging in what it's capable of doing, which is really fascinating. And the main reason that these people in those small numbers that we look at, I think they're scared. They're fallible, they're human beings. They don't know where to start. They don't know how to access it. They don't think it's for them. They're not capable of accessing it. These are human beings who are really terrified of this wonderful technological thing that we're creating. And we've been speaking and spending quite a lot of time with these people to see if there are other types of technology that give them the opportunity to engage in the services that they need every single day without having to pull out their phone or go on a computer and do things that they really don't want to do. It doesn't know me, I think, is a really interesting one at the bottom there. I don't know how well you can see this. This is a couple of screenshots from last week. So I was sent these by some people that we do research with, somebody in southeast London somewhere. She's got Parkinson's. And last week, she's in the 20% of people that don't really use the internet. On one side, she had a text message from her GP clinic saying, you've got to download this app. It's going to change everything. You're going to do all your digital stuff through this app. I don't want to use that app. I'm scared. I've got a tremor. My phone doesn't really work for me. And then the next day, she got a text message via an automated system, a piece of technology that the NHS has used, to basically say, you've got to use that app that we told you about yesterday, because we're shutting down our service that lets you do it the old-fashioned way. And when I spoke to her about it, when she sent me these screenshots and said, look what's happening, and she was asking me for advice, do I have to do this, because I'm an IT friend, she was terrified. She was really scared that she was not going to be able to just go down, knock on the door, have a chat to the lady on the desk or the man on the desk, book her appointment, get her prescription, do all that good stuff. She's in her late 30s, by the way, so she falls into this demographic of people that we assume are digitally savvy. Terrified, absolutely terrified. And when we asked some people, one Lloyds Bank actually asked their clients last year, 78% of those that weren't online said that they weren't going to go online. What would it take to get you to do your stuff digitally? Nothing, not interested. So we have to sort of look at technology, I think, in a slightly different way, which is this collaboration of people and technology, not tech for tech's sake. And the danger of the world that we're creating right now is we're probably creating too much design. We've probably put a little bit too much faith in the digitization of everything, because we're not digitizing behavior anymore. We're behaving in a digital world. Everyone assumes that everybody is digital, and really there's quite a lot of people who are the vulnerable people that need our help the most, and a lot of times, in a lot of cases, are not ready for it. So this is kind of the sobering moment where we go like, okay, let's just think about these people as humans, not users, and make sure we've got it right. There are technologies that are emerging, just to wrap up quickly. There are technologies that we're looking at that we think might be those dividers, those bridges. Conversational technologies are really cool. If my friend who'd got those text messages could have replied in the same way that she would reply to me, she probably could have had a chat to the service that had sent her the message, and they could have, or it could have explained to her that it's not really all that scary and coached her through the system. But instead, these are kind of automated pushes and nudges that get sent out, and there's no two-way dialogue that are happening. But conversational AI systems are in their embryonic stages. They're not brilliant at the moment, but they are on the rise. My dad, who's 75, doesn't have a mobile phone, but we put Alexa in his house a couple of years ago, and he's great. He talks to the lady in the box in the corner, and there's a whole other ethics issue there, but he's happy with her. He won't speak to me on the phone, but he's quite happy to speak to the lady in the box in the corner. The talking radio, he calls it. So look, I think everything that everybody in the NHS Digital and everybody in health tech services and everybody around the world that are doing technological things are all brilliant, and I love them to bits, and I think everybody's doing the right thing, but I think, a camel is a horse designed by a committee. And I think everything that's happening right now is so big and so bloated and so exciting. This is stuff, it has been around for a long time. AI has been around for 50 years, but we're 10 years into like the transformation of services, let's be honest. And so we have to make sure that we don't leave people behind. Thanks very much.
Awesome, thanks. Let me just have it check on the screen if we... Yes, there we go. We've got the right screen. Amazing. Well, thank you so much for all of these very, very interesting presentations. So what I thought I would do is ask you some questions first and then open it up to the floor. So please do prepare questions, as I think there's sort of nothing worse once we open up to the floor and everyone just goes completely silent. So please, I am counting on you. Do not do that. If not, I do know some of you in the audience and I will be picking on you for questions. So maybe just to start off, just a very general question. As a sort of summary point to this session, do you think then that digital healthcare has really delivered on its promises or not? And maybe we could start with Denise. Yeah, I think this microphone should be working. Oh.
So systemically, possibly with the exception of a country like Estonia, and maybe there are other exceptions where the national plan to use digital health has been executed, but their plan was relatively modest. It's primarily the electronic health record and access to the professionals. It hasn't. However, there are areas where there have been successes, and I would say that that those are areas where you can segment off something, where it doesn't require either reimbursement or the entire involvement of the healthcare system. So if we take social media, has scaled up and brought tremendous things to patients. Well, you can make the remark that it's also brought problems. And the other would be, and I'm not speaking specifically about the NHS and the booking service, but in general in the world, the online patient appointment system, because it doesn't interfere with the entire workflow.
Okay, thank you. Emma?
So I think we're definitely still on a journey to achieving the outcomes and promises set out by digital health. I suppose what I would say is that we now, and over the last couple of years, have some of the building blocks in place for that. And so the kind of foundations are in, so to speak, and that could be probably from an empower the person perspective, things like Wi-Fi across most of our primary and secondary care, real estate. Our content on our website is structured in a way that can be better syndicated. We've launched the NHS app to provide a consistent digital offer for people across the country. So some of those things are now in place, and we have the platforms that we can build on, working with the market and our providers of services. I think our focus now is how those things work together in that digital ecosystem and how they're supported by things like standards across the spectrum, from evidence to data to security.
Great. Pete, anything to add?
I mean, just I'm scared of absolutist language.
No,
right?
you don't have to. No one is forcing you.
When we say things like delivered,
right,
that terrifies me.
In the process of delivering?
We're delivering, and I think this is a journey, right? So this is something that's going to carry on for a long time, and I'm in awe of everything that all the NHS services do, and they're amazing, amazing, amazing. But, you know, you can put all of those things in place, but there's still 20% of the country that don't even have access to, you know, Wi-Fi. They have to go and stand on a hill and do that if they want to get access to these things. So you can build it, but it doesn't necessarily mean that people are going to come. And I think there's a bit of a divide between the services being provided and the service providers that are helping people get online. I think it's a really interesting collaboration that will happen in the next few years to make sure that those services are accessible. Because they are there and they are getting better and they are being worked on every day and the data is being collected, but it needs to be, people need to get there. And that's the journey.
So actually, sort of building on that point of inclusiveness, or how do you manage that, Pete? Because you've sort of pointed at, I guess, sort of different ways in which digital healthcare isn't particularly inclusive right now. So what are potentially the step changes that need to be done?
I mean, we could probably stop and take stock for a little bit, couldn't we? Because the world seems to move so quickly. And if I cast my mind back 10 years, that's when my son was born, and you know, I had my first iPhone. And you go, like, it's all happening so quickly. Maybe we do need to just slow down a little bit and just make sure that we're bringing everybody from the fringes into the middle. I mean, that's for me super duper important. But it has to be, I think everything that everybody's doing is correct. I think the speed perhaps it's progressing is something that needs to be really addressed, and we're responding to austerity in a lot of the digitization of services, and it's the elephant in the room, and we should not forget that. You know, this is about trying to cut people down because there's not enough money to pay for people. Let's not skirt around the issue. That's why digitization has been so aggressive. Comes at the detriment in some ways of a lot of vulnerable people, I think.
Right, but do you think that the reverse to that is also that it is potentially being able to increase access at points at which, I guess, the service sort of wasn't fully delivering? So the fact that you can, you know, access services potentially sort of 24/7, or that you can, I
mean, yeah, for sure. And I mean, it's a self-fulfilling prophecy in so many ways, which are people being more demanding, and therefore you create more services that are there on demand. But the world is mad at the moment in terms of technology. We should not forget that this is a very strange period in humanity where we're thrusting this odd entity into people's lives, and we do need to slow down just a little bit and go, like, what's the downside to all of this wonderful Silicon Valley-led glory? And I love it, by the way. I'm such a nerd.
You've drank the Kool-Aid too. So Denise, Emma, do you have any sort of points that you'd like to maybe add on the inclusiveness of digital health, or if not, we can happy to move on to another question.
Yeah, you could. I think I would want to speak about what I mentioned in conclusion about the need to encourage scaling up creativity. If we could take all these amazing minds out there and put them to work on how do we scale up, which would include bringing in the people that are not, then maybe we could take a step forward in that direction instead of multiplying experimentations about very narrow discoveries that are not necessarily going to concern enough people.
Right.
Yeah. And we have been doing some of those things. So we have a widening digital participation program within Empower the Person, which has produced the Digital Inclusion Guide, which looks to set some of those standards, as well as some pathfinders. I think there's between 15 and 20 that have been running over the last year in the UK. And I think what we need to do with that now is put that into our standard kind of approach to the way that we provide digital tools and services and enable choice, so that if you are going into a GP surgery, the kind of response that you get from the receptionist behind the desk when booking an appointment is the same response you would get via booking through the NHS app or another provider, so that it is consistent for people and a parallel service. So we'll be looking to ensure that localities within their plans for long-term plan implementation have some of those things at the heart of them.
Great. So given the time right now, I think it might be a good moment right now to sort of open up questions to the floor. Anyone has? Guy, thank you. There is a question right there. The mic is coming. So sorry, do you mind sort of introducing yourself and then
Oh, sure. Guy Borsmouth from the AHSN network. So interested in spreading the best new research, best innovations a bit faster than would otherwise happen. It felt like the three of you had a common interest in user-centered design or human-centric design. I just wondered if you wanted to sort of reference some of the best work you've seen, or to say a bit more about putting citizens at the heart of shaping services.
Who would like to start off? Denise, I think, she raised her hand.
So I have run a lot of startup contests and a lot of conferences where I curate the program. And what I have found the most successful are often inventions from the field. So either patient-led innovations or physician or nurse-led innovations. There is a British origin example, since I'm here, but you can tell I'm not British. 11 Health, which was created by a patient who was the 11th colon transplant recipient. And it's a connected stomy. And he has, because he lived in the system from the inside as a very frequent hospital patient, he then knew how to make the right contacts with the hospitals, how to organize the business model of his startup. He's received many awards. I could cite thousands of examples, but people that start from a real concrete problem in the field that they've personally experienced have the greatest chance of working out the kinks in the thing and getting it going.
Yeah, I gave a few examples in the talk, but I suppose user research is centre to everything that we do in terms of development of national products before they come into being, but also in terms of improving them and making sure that the feedback is received across the system as well. So it's something that isn't a one and done thing for us, but actually part of our day-to-day.
And one of the things that we looked at, especially in sort of AI in the mental health space, one we gave Prometheus fire. Like, there are lots of bedroom entrepreneurs trying to do the right thing and spewing out stuff that's not human tested, which is terrifying. In terms of stuff that I've seen that's amazing, quite often the best stuff I've seen design services are not digital. So we were working with a bunch of social enterprises in Birmingham in the Midlands, and they were trying to kind of reduce the rate of male suicide in this instance in Afro-Caribbean community, and they realized that actually technology wasn't going to be the solution because they had engaged with the local community, and so they went off and they taught barbershop owners basic counseling techniques so that the guys going in for their hair on a Saturday were having the right kind of conversations in a place they were comfortable. And so again, I think design doesn't have to conclude with a screen or a touch or a click or a button. Design is something with a big D, and it's much, much bigger, and it can be life-changing without a piece of technology in the equation, is my thought.
Great. Any other questions? Ooh, hands flying. Okay, so there's a woman at the back of the room, then a man here, and then we'll go to Phil.
So thank you very much. I'm Debbie Frost. I'm an Associate Medical Director at NHS England, but I'm also a working GP. And I suppose I'm very excited about tech, but when I go back to my general practice, the tech gives everybody much more access, and there's a real workforce problem. And I always think with tech, we just need to think about what we're not going to be doing as well as what what we can do with it. Being available 24/7 would be fine if there were enough, there was enough workforce to do that. So although it's great, I just wondered what your thoughts were about the limitations as well.
But we'll just take a sort of second question. There was a man at the back right there. I'll take those three and then I'll come to you.
Hi, my name's Donald Rentoul from Dexcom, and my question was for Emma on NHSX. One of Peter's points was 80% of people have access to digital technology. So we see reimbursement and funding of digital technology sometimes being uneven across NHS England. Are NHSX going to have a national platform for the national integration? Because that's the only way that we'll see fair integration of digital technology that's evidence-based.
Thank you. And we will take sort of one question here. There's Phil Aldrich at the front, and then Julie, those 4 questions, and then I'll sort of pass on to the panel.
Yeah, thanks. Just picking up on what Simon Seniors was saying earlier, he was saying we need to have a call, we need to talk about how to adjust the reimbursement framework to create a financial pull factor for the adoption of tech across the NHS. I just wondered if anyone had any initial thoughts on how this reimbursement framework should look.
Great, thank you. And Julie, just here, Poonam, right in front.
I'm Julie Dawson from Yoti Digital Identity Platform. I wondered if there was starting to be a change in terms of the humans, the patients, actually starting to want themselves. You mentioned lots of pockets of data, of people actually owning their own journey, their own conditions, their own data, given the fact that it might take another decade with all of the pockets of information spread. If you move 2, 3, 4 times across the country during your lifetime, it's very hard for those elements to be brought together. You might move to different countries, you might study or work in different places. So is there starting to be a tide of thinking of what are those identifiers that in some instances might be self-asserted, just an allergy? It might be that you have full records of certain more specific conditions that you yourself are given and empowered to take with you on your journey through life. Or where you're a carer for another person, you then start looking at permissioning, that you can permission another person to also act on your behalf. It brings quite a complicated landscape because you're then looking at that permissioning and also what is a verifiable claim and what is self-asserted. I'm doing some interesting work with an ESPRC project also looking at the anonymity and pseudonymity, because there'll be some bits of information that as a patient I am happy to share maybe with a peer who's also suffering from going through an HIV treatment, might be different with a medical practitioner, different with an academic organisation, and also different with a pharmaceutical company. But at a certain point the individual is looking, I think, for more control, and are we starting to factor that in?
Right, thank you. Okay, so there was a sort of first question on the limitations of tech, another one on reimbursement for healthcare technologies and the creation of potentially a national platform, which brings back again the question from Phil Aldrich, and then a final one around, I guess, sort of personalized health records, dynamic consent. So who wants to start with maybe tech limitations?
I'll give you a very brief answer to that, because I think there's a lot of questions that need to be answered. So I think the technology is emerging, GPs and so on and so forth are being given screens and optimizations and robotic process optimization and so on and so forth, and automation of tasks and things like that. But I think the metrics that we need to measure success by still need to be defined. You know, we should be asking how we want someone to feel, not what we want someone to do. And you know, I don't know how many of the workforce who are being given these tools and services are being asked, is this making your life easier? Is it making your life harder? Are you feeling less stressed, more under stress? So I think there's still some measurements that need to be done in order to grade the viability and the kind of success rate of some of these services, is my thought.
I would like to link two questions, the
Please,
question of the limits of tech and your data question. Healthcare is becoming recognized that healthcare data is ubiquitous, and this will happen through the smart city, with the fact that your car knows how much you weigh, could know about your many different data points about you, and even save you in the case of an accident, in the case of an incident, a health incident at the wheel. So the limits that we have today are, yes, very much related to the problem of pockets, that we're not seeing the whole person because of the separation of data. And I think we should look at the fact that it's going to be difficult going forward not to have a system like the X-Road in Estonia, where healthcare is just one part of an entire national collection of data about the individual. And not to go back to so I won't answer again about the permission one. I don't know if you've heard of a company called Humanity, which is working on a permission system where people would own all their data and then negotiate it with those who need to use it.
Right. Emma, would you maybe like to take the sort of questions on reimbursement and platform?
Yeah, I can answer the one on NHSX.
Thanks, yep.
So NHSX is a new joint team working to accelerate the digitisation of health and care, and is officially stood up on the 1st of July, so 1 month to go, but unofficially we are coming together already. So there's some still priorities to work through in terms of that, but our priorities from the outset are making sure that we set standards to ensure that technology is interoperable across the health and care system, publishing APIs for key national services, and developing a consistent and structured approach for the digital marketplace. So some of these things, as well as developing a new transformation model. So I think the funding and reimbursement question will come out in time, but it's something that we'll be working through.
Great. So I think we'll have time for possibly 2-3 more questions. Yep, there's one question there, one question here, and one from Harry Longman again. We'll get to you. Great.
Hi there, thank you. My name is George Dean from Incisive Health. We've talked quite a bit about the use of digital facing patients. I was just hoping we can maybe talk about some of the opportunities that are being given to clinicians. So I'm aware of some products that are coming to market at the moment that would allow for the prediction or escalation procedures and for the prediction of deterioration in patients. Obviously that shifts responsibility from the clinician back onto the software. And I just wondered, particularly from Mr. Trainer, if you could talk a little bit about the responsibilities of AI and when that responsibility shifts to developers.
Great. We'll just take one more question. There was Aidan, sorry, just right at the front here, and then we'll go to you.
My name is Eric Chowdhury from Future Advocacy. So instinctively, having the choice to use technology would make healthcare more accessible, right? Because if you're disabled, you can't leave the house, maybe English is your second language, it can make it a lot more accessible. But mandating it, obviously, will leave people behind. You don't really need to do any user research for that. So the example you gave of the appointment system is clearly a really poor decision to mandate people to use one specific channel. What do you think is the main driver behind that? Is it just a lack of money, or is it, how is it smart people are making such poor decisions?
Great, and there was one last question from Harry Longman. Just there. Oh, yeah, she's coming.
Yeah, Harry Longman, Ask My GP. Can I really support the last speaker's question and also echo Pete's point about digital exclusion? One of our aims is that we make it easier for non-users. And that is simply by making things more efficient so that the non-users have more access to the stuff without being forced down a particular channel. Now, question for NHSX, please don't take this personally, Emma. But I think there are some things going wrong here. One is that you are saying 25% of appointments must be bookable online. Well, that takes out 25% of appointments for non-users. You're reserving capacity there. And I think the other point is, how are you going to get providers involved? One of the things we notice is you've got to make things easier for patients, but also easier for providers, for GPs. If they don't see life as easier, they won't use it. And I think this is why the take-up of the NHS app has been so low, because actually GPs don't want to let patients book their own appointments face-to-face when 2/3 of them won't be needed as face-to-faces. So if you could speak for your department, that would be nice.
Right, thank you, Harry. So we have about 1 minute left, so answers will have to be very, very short. So Pete, around responsibility of AI.
Very quick answer, they're not users, they're people. Like full stop, just stop saying it, dehumanizes everybody. The reason I'm grey, tired and a bit stressed at the moment is the responsibility of an AI system that goes wrong is my responsibility. It's not a machine making a decision and therefore it's its responsibility, or the NHS that push it out or whatever. It's the software provider's responsibility, and quite a lot of software providers have very slopey shoulders and say, well, it's an algorithm, blah, 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 and so on and so forth. We don't know what's going to happen. If we ship it, it's our problem, and we should be responsible for it. And my insurance policy at the moment doesn't quite cover the unknown, so that's the big problem.
Great. Emma, maybe the question about...
the appointments. Yeah, so the 25% of appointments being made available via the NHS app, I believe, is from the GMS contract commitments. Is that what you're referring to? Yeah. So, like I said before, I think, it doesn't mean that those appointments are carved off, but you should get the same experience no matter which channel that you choose to engage in. So it's to make some of those appointments available, and obviously we need to make it easy for GPs to adopt those and implement them, and we have our implementation team working on that at the moment.
Great, awesome. Denise, any last words on some of these questions?
No, it's been a very rich session, and I think that there's a lot of work out there, and some good ideas have been forwarded. Let's listen to the patients and the professionals.
Great, awesome. So thank you very much for this very interesting sort of talks and panel. We will now break for about half an hour. So if you could basically sort of all have a lovely snack at the back of the room, hang out here, network, have fun, and then come back to your seats at 10 to, what time is it now? Gosh, I don't want to give the wrong time, 10 to 12. So thank you very, very much, and please thank our speakers.